Welcome to Grand Rounds for special topics for April 2026. Our special topics this month are multimodal shoulder instability management and also graded motor imagery. So we first have Dr. Guarino, who earned a bachelor's degree in science from Pennsylvania State University and a doctor of physical therapy from Moravian University. She is currently chief resident in the St. Luke's University Health Network Orthopedic Physical Therapy Residency. She's committed to creating a supportive and welcoming environment for her patients, emphasizing individualized care and patient empowerment. Her background in high school and collegiate athletics provides her with a unique understanding of the athlete's mindset, which informs her approach to rehabilitation and performance optimization. Dr. Guarino currently practices at St. Luke's in Phillipsburg, where she focuses on treating athletic and highly motivated individuals of all ages who seek to return to their prior level of function. She integrates manual therapy with movement-based interventions to help patients achieve their full potential. Outside of patient care, she enjoys spending time with family, staying active through exercise, coaching, and playing basketball and reading. And second, we have Dr. Poepoe, who earned a bachelor's degree in biology from Kane University and a doctor of physical therapy from DeSales University. He's currently a resident in the St. Luke's University Health Network Orthopedic Physical Therapy Residency. His passion for physical therapy began after experiencing a back injury while playing basketball in high school, which gave him firsthand insight into the rehabilitation process and the importance of comprehensive care. Dr. Poepoe currently practices at St. Luke's in Stroudsburg, where he emphasizes a holistic approach to patient care, recognizing that health and wellness encompass both physical and mental components. He is dedicated to creating individualized treatment plans tailored to each patient's unique needs and goals. Outside of patient care, Dr. Poepoe enjoys spending time with family and friends, competing in disc golf and recreational running. As a reminder to everyone, make sure that you use the QR code on the right hand of your screen or the code on the left side of your screen to sign in to EADS and complete your quiz and your course evaluation in order to get CE or CME credit as appropriate. And for your convenience, I also put it in the chat. And if you're watching the recorded version, you're already in, so just make sure you take your quiz and your course evaluation. This is our statement of need, and the target audience is all providers. And this is our designation statement, and the planners and presenters have nothing to disclose. So without further ado, I will turn this over to Dr. Guarino.
All right. Hi, everyone. I'm Brianna Guarino. I have my presentation titled The Multimodal Approach to Treating Shoulder Instability. These are my learning objectives. And I have a quick story time. Shout out AI for creating this little character drawing of my brother. So in December 2014, my brother's senior year of his football season, he dislocated his shoulder for the first time. He had to go to the ER to get it reduced after trying multiple times on the field. He decided he wanted to play 2 more games because he had his championship game coming up, and they won, so that's exciting. After the championship game, he had surgery involving a Bankart repair and a Hill-Sachs lesion repair. Following surgery, he participated in formal physical therapy for 3 months, and then he returned to sport preparing for his collegiate football season. Now, the following year, October 2015, my brother experienced another dislocation while playing in a game. After this dislocation, my brother remembers needing to be sedated in order to get that shoulder reduced. He ultimately decided no surgery and instead did a strengthening program with his athletic trainer and workouts with his teammates in the weight room. Then, on the following year, during his second season of collegiate football, in August of 2016, during training camp, it dislocated once again while simply having a catch with one of his teammates. He ultimately decided it was time for another surgery. He underwent a surgery for a Bankart repair. After this surgery, he participated in formal physical therapy and athletic training and discharged when appropriate for return to play. He went on to play 2 more collegiate football seasons and has not had a dislocation since. So, why am I telling you this story? The shoulder is super complex, and knowing when to treat conservatively versus when surgery may be indicated, as well as understanding that structures beyond the glenohumeral joint can contribute to instability, is essential to optimal patient care. Shoulder instability is considered a multifactorial condition involving structural, neuromuscular, and psychosocial contributors. The shoulder is the most dislocated joint in the body, with anterior dislocations making up 98% of cases. Individuals at higher risk of shoulder instability are going to be our 20-year-old males, individuals playing in contact sport, and our military personnel. The reoccurrence rate is greater than 50% in younger athletes after undergoing a Bankart repair. So it is not uncommon for reoccurrence like my brother's to occur. Now for a brief anatomy review. Like I said, understanding all structures around the shoulder joint is going to be important for us to provide the best care for our patients. The shoulder is an inherently unstable joint. Think of a golf ball on a golf tee. It relies on ligaments, cartilage, and muscle to provide stability. When one is damaged, we need to address all of the structures. It is important to keep all structures in mind when assessing, diagnosing, and rehabbing the shoulder. On the top left, I provided an image to discuss our dynamic stabilizers. Most people instantly think of our rotator cuff, which is made up of the supra, infraspinatus, teres minor, subscapularis. When thinking of the shoulder, you also want to be aware of the scapular stabilizers, such as the serratus anterior, trapezius, rhomboids, deltoid, and the levator scap. Additionally, I want to add in the triceps and the biceps because they also play a role in shoulder mobility. On the top right, I included an image that shows the ligaments that surround our glenohumeral joint. The two that stick out to me the most are going to be the glenohumeral ligament, which is made up of 3 fibers attaching the glenoid to the humerus, and our glenoid labrum, which provides a suction cup effect and deepens the glenoid socket for the humeral head to sit in. Lastly, in the bottom middle, I provided an image to of our brachial plexus, which does not necessarily provide stability to the glenohumeral joint, but I wanted everyone to keep the nerves in mind as we discuss shoulder instability because they are so closely related to the joint. This is a traditional classification system in which we distinguish traumatic versus atraumatic shoulder instability. First, we're going to discuss the Tubbs classification. This is going to stand for traumatic, which is our higher energy mechanism. Typically, it's unidirectional, most commonly anterior. You may see a Bankart lesion involved with this, which is a labral tear from anterior to inferior glenoid. And typically, this classification is going to require surgery, but it does often have a high reoccurrence rate. Later, we'll discuss our Imagery classification, which is our atraumatic individuals. Instability is typically seen in greater than one direction. It's frequently affecting both shoulders. The recommendation for this classification would be 6 to 12 months of structured PT. And if surgery is needed, it's typically an inferior capsular shift. Immediate imaging is our first line of treatment post-reduction, and it's important to rule in or out pathology that requires surgery. The first line of imaging that we'll see is going to be a radiograph, which is typically taken in 3 views. We might see greater than 8 millimeters of distance between acromion to humeral head, and this is going to indicate a subluxation. More sensitive imaging can be taken, such as a CT scan or an MRI. So, what might prompt us to get a patient in for surgical consult? Number 1, we're going to see abnormalities in imaging. And then some special tests that may be looked at are going to be a load and shift test, apprehension relocation test, and a surprise test. Many of you, like myself, might not know of a surprise test. That's because it's not a very nice test. And in my opinion, I think we get what we need to know from that apprehension relocation test. Immobilization timelines is a topic that varies when discussing shoulder instability. If surgery is declined by patients or the patient is not a good surgical candidate, then we may discuss that immobilization. Keeping in mind, there's no level 1 or 2 evidence on timeline for immobilization, but on average, what I found from research is that if it is an individual's first time dislocating, they may be immobilized for 2 to 4 weeks in a sling for protection, pain management, and reducing muscle guarding. There's no significant evidence of immobilization reducing our risk of another dislocation. There was no evidence in the research to suggest that greater than 1 week of immobilization for patients less than 30 years old would be beneficial. And there was debate on which position to put that sling in when they're immobilized. The one common factor I found was that patients put in an external rotation sling were less compliant with immobilization. Then onto our reoccurrent dislocators. Immobilization is not typically recommended, and physical therapy should begin immediately after. There are some individuals that can even return to sport same day if the reduction is easy, it's minimally painful, and they demonstrate full range of motion after. Now, let's discuss when it would be appropriate to refer to rehabilitation. This will include our Imagery classification cases. In an atraumatic case, it may be more beneficial to achieve clinical signs first. It's unlikely you'll damage that joint, and achieving clinical signs allows providers to be able to use interprofessional skills to consult with the radiologist on what to look for based on findings. Some clinical signs we may see are multidirectional instability and a positive sulcus sign. Some providers may perform a gross hypermobility test using that Beighton scale. The Beighton scale is made up of 9 points. It's pinkies extending past 90, thumbs touching the forearm, elbows hyperextending. We would get a point for either side. Another scoring point would come from trunk flexion if our hands are touching flat on the ground, and knee hyperextension, again, a point for each side. Greater than a 5 out of 9 on this scale would indicate gross hypermobility. On this slide, I included a few pathologies that are associated with shoulder dislocation. These are all good reasons for why providers need to understand the entire shoulder joint. If the labrum is involved, we may see a Bankart lesion caused by anterior dislocation. A Bankart lesion is an anterior-inferior lesion to the glenoid labrum. We may also see a slap tear, which is a superior labral anterior to posterior lesion, often affecting the biceps tendon, as it is the attachment point of this tendon. As for bony pathologies, imaging can find a Hill-Sachs lesion, which is a fracture to the posterior lateral humeral head caused by anterior dislocation when the humeral head passes the rim of the glenoid. Lastly, as mentioned before, the brachial plexus runs alongside through the shoulder structures. Therefore, one, if not multiple, nerves may be involved in these instability cases. A systematic review found the incidence rate of nerve involvement varied from 0.4 to 65.5%, with axillary nerve being the most common. Reported nerve injuries vary so widely due to the definition of nerve injury, diagnostic methods, patient population, injury mechanism, and timing of assessment. Our individuals that are at higher risk of nerve involvement are going to be found to be the older adults with low energy mechanism, as well as our younger males who are in contact sport. I provided this slide to give a brief overview of what we may see with nerve involvement. In the first column is second column is the axillary nerve, which is the most common nerve involved in the anterior shoulder dislocation. With axillary nerve injury, we may see motor deficits in the deltoid, leading to altered movement patterns and inability to raise their arm. We can see sensory deficits over the lateral shoulder, and we may even notice a lack of muscle mass at the shoulder due to muscle atrophy. In that third column, I included brachial plexus. It's in place because research discusses various nerve injuries with dislocations, but they are not nearly as prevalent as that axillary nerve. Motor and sensory involvement will be based strictly upon which nerve is involved and whether it is one nerve in isolation or multiple nerves involved. For example, if the radial nerve is involved, we might see loss of wrist extension and a sensory deficit over the dorsal aspect of the forearm. Another example, if the suprascapular nerve is involved, we may see supra and infraspinatus atrophy and difficulty with abduction and external rotation. The following two slides are going to be a review of published guidelines for post-op shoulder instability. While looking at these, take note of the variability of sling use versus no sling use and how long each one is recommended. The one common take-home message between all of the guidelines is avoiding combination movements such as abduction and external rotation to end range, as this puts high tension on anterior capsule. I'll review a few of them. I'm not going to go over all of them, but just that top row, Botany 2002. Immobilization is recommended. They recommend 4 weeks in immobilization. They're able to begin passive range of motion and isometrics at week 1, and these individuals are allowed to begin active range of motion as well as strengthening at week 4. Going down, we can look at Dickens 2017. Immobilization is recommended. The duration of time is 6 weeks. They're unable to perform passive range of motion or isometrics or any movement until that six-week period. At 6 weeks, they can begin active range of motion, and then later at 12 weeks, they're able to begin that strength training. We can look a little further down to that last row. Aaron 2019, they recommend immobilization for 4 weeks, and these individuals are able to begin isometrics at 4 weeks, but unable to begin passive, active range of motion, strength until week 5 when they're out of that sling. I'll go over a few more. Gibson's 2016, they don't recommend immobilization, and these individuals are able to begin passive range of motion, active range of motion, isometrics, and strength all at that week 1. Lastly, we can look at Milkstein, might have mispronounced that, sorry, 2016. Recommendation for immobilization is 6 weeks. They can begin passive range of motion at 1 week, active range of motion at 5 weeks, and strength training at 7 weeks. So as we can see, the timeline for immobilization is very variable, but most common takeaway point would be to reduce full abduction and external rotation to ensure that we're not providing too much tension on that anterior capsule. Lastly, how do providers treat an inherently unstable joint, whether it be post-op or non-op? First things first, the patient needs to develop motor control. Focus should be on quality of movement and kinesthetic control before loading a patient up. Majority of patients who come in with our Imagery classification, that's our atraumatic multidirectional instability, they're going to demonstrate abnormal scapular motion and muscle pattern activation deficits. If we strengthen without restoring motor control, we may be reinforcing that dysfunctional pattern. The list I provided is not an end-all be-all list, and it simply includes some of the motor control techniques I have used in the clinic and what research has shown. We can address things like isometrics, which in some cases acts as an analgesic for our patients who are still having pain post-reduction or post-surgery. We can look at scapular kinematics and positioning. If we look to the right, you can see a provider who appears to be utilizing tactile cues with their patient in order to ensure proper muscle activation with shoulder elevation. We can also look into rotator cuff recruitment without load, which we see in that top left image. In the bottom image, you will see a patient performing movements through PNF patterns such as D1, D2 flexion, which is important for everyday movement. And lastly, I included providing perturbations to improve activation of our dynamic stabilizers using things such as rhythmic stabilization. Once the motor control is where we want it to be, it's important to increase force producing capacity and endurance, and that's where our strengthening comes into play. Again, this is not an end-all be-all list, but instead a brief list to provide some of the ideas for treatment. We can begin loading for rotator cuff, strengthening, being sure to perform at 0 degrees and 90 degrees, especially for our overhead athletes. Our patients can perform deltoid strengthening to provide the vertical force of that shoulder joint. We may want to think about performing exercises in full can position for higher infraspinatus and subscapularis activation, and also to provide less risk of that shoulder impingement position. I also included scap retraction, performing things to address that scapular stabilization. Now that we understand it's important to treat motor control prior to strengthening, I wanted to provide us with a slide that makes us keep forced couples in mind. As you can imagine, if one half of the couple is not holding up their end of the deal to the other half, or the other half is forced to be overworked, which leads to movement dysfunction and makes an individual susceptible for injury. The first force couple I included here is going to be the deltoid and the rotator cuff, which offsets each other with their vertical and horizontal forces. Next up, we have our upper trap and serratus. I also like to include the lower trap. Together, they act as our scapular upward rotators. One force couple example is if the serratus anterior is not activating properly, we may see upper trap overcompensation, which will result in a faulty movement pattern and increased shoulder shrug. Lastly, I included the anterior and posterior aspects of the rotator cuff. A common imbalance we frequently see is an overdeveloped subscapularis, leading to an increased internal rotation versus external rotation strength ratio. Now for a wrap up, understanding all structures involved in the shoulder girdle and what provides stability to it is important for all providers in a patient's care team. Knowing the two classifications for shoulder instability will help us to understand what to expect. No, it is important to utilize imaging post-reduction to rule in or out pathologies that may require surgery. Know when to refer for surgery versus when to treat conservatively, and knowing that it is important to address motor control before strengthening to reduce risk of further dysfunctional movements. Questions?
So please make sure if you have a question, type it into the chat or unmute yourself and ask. I actually do have a question. You know, in your brother's case, which I think was a great case of multiple different options, many times directed by the patient's choices. How do you manage ideal practice with patient desires?
I think that's going to rely heavily on patient education, educating them on what would be the outcomes if they were to get the recommended surgery versus if they don't get it. My brother was highly educated and he knew the risk of redislocation and still chose not to get it. Maybe because it was middle of season or whatnot and he wanted to play. Being a young athlete, I understand it. But I think patient education is going to be our top priority in cases like that where the patient is going against what would be medically recommended.
Cool. And then another question that I have for you is, after doing all of this,
Yeah.
Is there anything you would have advised him or other people in similar situations to do differently than they did?
Because I don't know what his full rehab process was and how well motor control was established before going right into a strengthening program. I can't, for his sake, I can't really say that I have an opinion on it because they might have done everything right, and the reoccurrence rate being so high as it is, it might have happened regardless, right? So,
Excellent.
yeah.
Thank you.
All right.
Cool. There is a question in the chat. What's your take on closed chain exercises to improve motor control and proprioception? Is it something you'd recommend, or would you usually stick to open chain?
I think inherently I have began with open chain stuff on the table, but when I was doing this PowerPoint, when I talked about the perturbations and like rhythmic stabilization, what came to mind was being in a press up on like a Bosu ball, which is unstable, and providing taps at Bosu ball. So I think I would honestly do both. And it is going to depend on the patient and what they can tolerate too. Because if this patient's in high levels of pain, you might not see them in that closed chain loaded movement.
Yeah. Thank you.
Yeah. Okay.
So now we're going to transition to Dr. Poepoe.
All right, how's it going? All right, so today I'm going to present about greater motor imaging. So let me paint the scene real quick. Imagine you get an evaluation of someone coming in for left hand pain, and they're telling you that there's intense pain that they're having, numbness and tingling, feels like it's burning, feels like their nails are digging into their hand, but upon examination, you look at the patient, they actually have a left arm amputee. So they're telling you they have all this hand pain, but they don't have a left hand. Let's say later in the day, you have another evaluation as well for someone who's coming in for chronic right ankle pain and their foot is burning. They can't put on a shoe. They're basically living inside this cam boot they're having in, and putting on the socks is too much for them. They can't even walk without the cam boot at all. What if I told you there's a way that we can sneak around the nervous system, its own alarm system, and with this, we can use it to kind of turn down the volume with the pain that these patients are having. This is what today's topic is going to go into a little bit more. And I want to start with going into a little bit more detail about what pain phenotypes are best for this. So we have three main pain phenotypes that go into every pain: nociceptive, neuropathic, and nociplastic. I'll go into a little bit more detail about what patient fits into those buckets there. But what I really like about this image that I have here is it all kind of blends together, as all pain consists of these three pain phenotypes. It's our job, though, as clinicians, to figure out which one is this patient having the most dominant pain of. So nociceptive pain that occurs from nociceptors in our body, that is from actual or threatened damage to non-neural tissue. As you can see to the image to the left, that's not going to be great for them, right? They're going to have damaged tissue stepping on that nail, but something that we can see as well with strains and sprains throughout the whole entire body. Usually patients present with this with more, they point to right to the spot where it hurts or a general area where it hurts from there. And this is the most common type of dominant pain that we see in the orthopedic physical therapy setting. The next one being neuropathic pain, so pain arising as a direct consequence of a lesion or disease affecting the somatosensory nervous system. A classic one that we usually see is, what I have pictured on the left, is lumbar radiculopathy, where they might have that radiating, numbness, tingling, burning pain through a specific dermatome. Can be seen with cervical radiculopathy as well. These type of patients that have pain arising from a specific nerve that's causing their symptoms. And this leads us to our third pain phenotype, being nociplastic pain. So pain arising from altered function of pain-related sensory pathways in the peripheral nervous system and the central nervous system without clear evidence of tissue damage or somatosensory system pathology. As you can see in the picture on the left, showing the patient having pain in their hand, but it's more of that top-down approach of where they're having that pain from, where imaging and EMG studies might be unremarkable, but yet they're having this intense pain. So how can we rule someone up into this from here? So usually we can look at four different things. Do they have disproportionate amount of pain? So is this pain unbearable for them? Disproportionate aggravating and easing factors. Nothing really makes it worse, but nothing really makes it feel better. Just kind of always there all the time. And also diffuse palpation of tenderness. So is light touch really difficult for them, where it feels like there's a lightning shock that just went through their entire affected body part? And also psychosocial issues, which you could use patient-reported outcome of on a rebro to kind of rule it up a little bit more. Is there a psychosocial issue going on with them too? If someone has all four of these in this category, there's a 486 times likelihood that someone fits into this category a lot more. So what can we do with this patient? Bunch of things. Patient education, pain neuroscience education, our topic today of graded motor imaging, graded exposure and activity, and cognitive-based therapy. That multimodal approach is going to be good for someone that you find that fits into those categories for being nociplastic dominant pain. But let's go in a little bit more detail about graded motor imagery, kind of figure out how can we even implement it and how do we even start. So what is it? It's a top-down rehabilitation technique. So instead of going to the body part and treating that specific body part, you're going more so for reducing that cortical smudging that's occurring for the patient of why they're having that pain. So there's three sequential components that needs to happen from there. First one being laterality recognition, second one being imagined movements, and the third one being mirror therapy. I'm going to go into a little bit more detail about this, but we're going to talk about why it's important to start with that rather than just rushing right into mirror therapy, or even why each patient needs to do it. Most of the time, patients spend around 2 weeks for each component with this, but it can vary from patient to patient with this. So let me talk about the first one right here with laterality recognition between right and left discrimination. And this can be used for hands, feet, neck, low back, shoulders. And what I usually technically like to use to kind of rule this in is the picture to the right showing the Recognize Foot app. This app I really like just because I can use it as a good photo bank vault. So sometimes some laterality apps I've looked at kind of have the same picture, same 100. So if they play a couple games of it, they're kind of seeing the same things. Just comes down to memorization. With this too, I can use this to kind of find if they have that lack of laterality recognition. Do they have a deficit with it? And current research shows that normative data for this is being 80% or more accurate and depicting between a left or right image in less than 2 seconds. And with this, you can give this to your patient and see how they score and kind of keep on letting them run this. So then that way they can build up their laterality recognition. And there's differing levels for this too. The app also describes why they're completing this too and the science behind it as buy-in for this for the patient, and also explaining why we're completing this is going to be key and essential for the patient also understanding what's going on with the plan of care. Prescription difference with patient tolerance, as some patients might complete this and feel an immense amount of pain, and kind of setting up goals of only completing these within tolerance is imperative for them. So that way they don't get discouraged throughout as well. And whenever they meet that normative data, that's their next step to kind of move on to the next step of imagine movements. So this is not a patient imagining someone else doing this. This is not the patient viewing themselves doing it from a third person view, but from their own point of view. A good one is if someone has hand pain and they have trouble writing their name down, you can break it down into a little bit more smaller movements from the functional one, such as bringing thumb opposition or pinching as well, and make them mentally imagine that. Again, knowing patient tolerance is going to be key because some patients might have pain with this as well throughout. So making sure you only have a specific time frame for them to complete this before it becomes intolerable for them. There's also newer research out there too, implementing manuals with imagined movements, such as a therapist completing an A to P motion in the talocrural joint to simulate dorsiflexion as the patient is imagining heel strike with ambulation. The third and final step and components of greater motor imagery is mirror therapy. So the key thing with this is making sure the mirror lines up with the patient's point of view of the opposing extremity. And you can be a little bit more creative when it comes to neck and back, but using a mirror box is generally recommended for this. And you can use this to mimic movements occurring. So if a patient has a deficit on their left side, they can move around their right hand and can visualize themselves thinking that they're seeing their left hand move and mimicking that. You can also use it to incorporate tactile and sensory things. So that way they can help reduce that hypersensitivity that's occurring in that affected joint. So how can we track our progress with this? One thing that we can do is applying pain pressure threshold. So how much pressure using a potentiometer can a patient handle before pain occurs? Also, one scale that I like to use is the Tampa scale of kinesiophobia. This way we can kind of track to see, does a patient think that exercise is going to make this worse? Do they think movement in general is going to make this worse? And this way we can see as the patient's symptoms decrease with greater motor imaging, they can feel more confident with moving that affected body part from there. So I want to go into a little bit more current literature of what's out there. This one is a little bit of old, but 2013 systematic review and meta-analysis based on greater motor imagery and its components on chronic pain. And it showed that with laterality and imagined movements just alone, it didn't really show any effect. But with the full protocol and just mirror therapy alone, they saw it had a large effect size from there, showing that there was a difference with these patients coming with chronic pain and implementing greater motor imagery. There was a change in their outcome. This single-blind randomized control trial had 20 patients, 20 groups, 20 patients total, 10 groups with a 6 weeks trial. Both these groups had symptoms for more than 6 months, pain into that moderate severe category, confirmed with an MRI of shoulder pain, and one received greater motor imagery while the other one did not. And what they found in the outcome with this is that they found that the group with greater motor imagery had their pain reduced sooner than the other group. But one limitation I found with this study was it didn't really discuss pain phenotype and pain dominance with this. Was each patient for this a nociplastic dominance that would benefit from greater motor imagery a little bit more? Something that wasn't really answered into this article, but at least showed some improvement in general pain when using greater motor imagery with chronic pain patients. Another one here was a randomized controlled preliminary study. Again, another 20 patients, so a smaller sample size, but 10 people did 10 weeks course of PT with motor imagery, while the other one did not. And this one used a little bit more of my outcome measures that I like to use, such as the Tampa scale for kinesiophobia, and found an improvement in that throughout the time period. Also, appearance perception. So, especially when it comes to like CRPS, they might have changes in swelling and hair loss, and they have a better appearance perception of that and function. So, if they had CRPS of their foot, they might be able to walk now. This other article I have is a really good article from Lotz and Mosley. It helped make up that protocol of that laterality recognition, mental imagery, and also mirror therapy of why that occurs in that sequence from there with that primary somatic sensory cortex, and using that visual perception to help reduce that overall pain or reduce that cortical smudging that is occurring as someone has that chronic pain from the patient's nervous system being on high alert. So let's talk about a case study about someone who may come into your clinic. Let's say you have a 40-year-old patient that is 3 months right foot injury after kicking a door. So she got angry and just kicked a door from there and hurt her foot. Thought nothing of it, hurt for the day. Next day, she woke up still in pain. Ends up going to urgent care, getting imaging done. Imaging found to be unremarkable. Then they said, just put on this cam boot. You're going to wear this and just it'll heal on its own. As time goes on, she comes to you 3 months later saying the pain's even worse, or she can't live outside that cam boot. She can't even go to work now because it hurts to drive on that foot. She can't even handle putting her foot onto the pedal. Even socks and shoes just feel straight up uncomfortable, like it's stepping on glass to put them on from there. And there's widespread pain, and noticing color just changes, and notice it gets hot and cold throughout the day. So where do you even start with this patient from here? Of someone who can't even live outside this cam boot. So through the physical exam, you look at red flags, unremarkable for it. You complete a lower quarter screen, hypersensitive to light touch over L4, L5, and S1 dermatomes, otherwise unremarkable, which makes sense for that as those dermatomes lie within the ankle and foot region. Ankle range of motion found limitations with dorsiflexion, with only lacking 20 degrees of dorsiflexion. Plantarflexion of only 40 degrees and inversion of 15 degrees. Couldn't really assess gait due to her being unable to leave that cam boot, and also strength-wise was deferred due to sin. So it's the severity, as if I tested this pain, this patient would not want to stay around much longer for the rest of the evaluation. So how do you even further evaluate this? You can use patient-reported outcomes, such as the Cerebro, to kind of rule in if there's any psychosocial issues going on there. Does she fit that other categories that we discussed earlier to fit into that bucket of being nociplastic dominant pain? You can also use the Recognize app to help rule in a lacking of laterality recognition, going back to that normative data of does she score less than 80% accuracy and take longer than 2 seconds per image? Is that something that we need to address through this? So now you have this patient who can't even put on socks because it hurts so much and doesn't really want to move it. What do you even do the first day? Lots of patient education, expressing to the patient that it's okay to move around, but within their tolerance as well, and discussing how you're going to approach pain neuroscience education and greater motor imagery with that top-down approach in patient-friendly language, discussing to them that this is going to be helping us turn down what's going on with your nervous system. Since you had this injury, this will help calm things there so we can get you back into driving, to putting on shoes and socks just to walk without needing a cam boot. And also that laterality training. Using that buy-in for that patient for this is going to be essential, as most patients go into physical therapy expecting hands-on treatment. And if you tell them to download this app they have to buy at the App Store, it requires a little bit of buy-in from them to do so, but explaining the importance of it and explaining how we're going to achieve through this. So how do you keep track of all this too? Follow that sequence of greater motor imagery, starting with that laterality recognition, up into the point where they have complete accuracy and underneath that total time frame for each image. But does it change their comparable sign? If a patient comes in with foot pain, does it change their ability to put on a sock? Does it change their ability to walk? With someone with hand pain, does it change with their ability to write something down? Each phase should be around 2 weeks, but can vary patient to patient. But pain pressure threshold is also another way that we can keep track of this as well from session to session. So other considerations is, well, what may have been the main driver of the symptoms? Why did they fit into that nociplastic dominance pain? Cognitive-based therapy is going to be key for that, and something that is within our scope of practice too, discussing about stressors in life, discussing about what may have caused their kinesiophobia, and even pain catastrophization as well. And that's a scale that you can use on top of that to figure out why their symptoms might be occurring like this. Goal setting is also going to be important for that graded exposure, as if they were walking 10,000 steps a day, they can't go from walking in a can boot, staying off as much as they can, to 10,000 steps. They're going to go, all right, let's plan for the end of this week going at 1,000 steps per day and move on from there. So overall, in summary, understanding the pain phenotypes of that nociceptive, neuropathic, and nociplastic pain, and how effective greater motor imagery is for the patients that lie within that nociplastic dominance pain. The proper way of utilizing that greater motor imagery with using that laterality recognition, mental imagery, and mirror therapy, how we can track it with our outcome measures, and also current literature showing that it can be pretty effective for our patients with this chronic pain. Any questions?
Drew, I have a question.
Please.
So nice job. With this particular, we can be specific to the patient you presented on.
Yeah.
How do you go about setting the expectation for that patient from an improvement standpoint? Every patient that comes in wants to know how long it's going to take them to get better. And with this particular population, how do you approach that with them?
Yeah, great question. So usually how I approach it to them is I like to use metaphors. Metaphors is great when implementing education for them. I tell them it's basically like climbing Mount Everest. This isn't a simple task, and it's not something quick to do. It's usually I explain that this can take months, if not a year plus, for things to kind of calm down overall, to get back into it, depending on the chronicity of things too. But it's a hard process, is what I try to explain to them, that this is not a quick fix from there. This is something that takes a little bit more time.
So there's a question in the chat.
Yep.
Is there a difference between internal motor imagery, in other words, seeing the self perform the movement through their own eyes, and kinesthetic imagery, feeling the self do the movement not in a third person view? So does it matter whether you're doing motor imagery from a first person perspective or a third person perspective?
Yeah, so you want to do it through a first person perspective with it, mainly because you want to imagine yourself doing it. As you're doing the movement, if you have that kinesiophobia, you want to be able to see yourself perform the image, not coming from afar. Usually the neural pathways, especially what's going on in the cortical processing of it, stems from the actual visual perspective. That's why with mirror therapy, we want to make sure it lines up with the patient's perspective of it, not someone else's.
And if they have a really high fear to themselves moving, do you ever start in third person and then move towards first person, or do you always start at first person?
I start with first person first, just to kind of get a baseline with things, and moving more distally away from the specific movement, or moving into the smaller movements of that functional task. Please.
How much time do you spend with pain neuroscience education and the patient's understanding before you get into graded motor imagery?
A decent amount of time, to be honest. I'd say it takes a couple visits before I get the full buy-in from a patient. Sometimes I feel like around the third visit is when I start to get going with graded motor imagery a little bit more, mainly because when I present it to them, they come into the next visit with a bunch of questions. But usually that pain neuroscience education is going to be great in terms of that buy-in of why we're completing this in the first place.
And as a follow-up, if you don't get 100% buy-in, are you still going to graded motor imagery?
No, I need full buy-in from them, to be honest, and I want the patient to feel involved in their plan of care. especially with their kinesiophobia. I don't want them to feel like I'm making them do something they're really fearful of. Otherwise, that might cause things to get worse from there. So I want them to feel comfortable with this and understand of why we're doing these things as well.
Thank you.
Yeah.
And off of that, another question in the chat is there ever an issue with insurance coverage with this particular treatment? And then I will dovetail onto that question. How do you generally bill for this?
Yeah. So insurance, I haven't had any issues with insurance with this personally, but I implement this as a top-down rehabilitation approach with this, more of a neuro re-education, as with pain neuroscience and greater motor imagery, grouping them into that category there, as we are working on the nervous system from that standpoint. Maybe not a usual body part like we would with a nociceptive or potential neuropathic outcome with it, but with this nociplastic dominance, I haven't had any issues with insurance with it or billing it in an improper way. I think it fits in perfectly with neuro re-education with this.
So similar to any other education you provide, it's based upon the intent or the purpose of the education and how you bill it.
Correct. Yeah. If you're telling a patient of why a McKenzie-based approach is important, why they need to do it multiple times per day, I think that's the same amount of education that you give for someone about reducing their overall pain that they may be having from their nervous system being hyperactive.
Excellent. Thank you.
Mm-hmm.
Any other questions for either Dr.
Please.
Guarino or Dr. Poepoe? So I do have another question about the graded motor imagery.
Please.
Do you always start with laterality, or are there ever cases where somebody doesn't really need to focus on the laterality and they can skip right to the motor imagery, or even all the way to mirror therapy?
Yeah, so I haven't personally had a patient with that, but the purpose of it is to also going back to that normative data as well. If they're already surpassing the highest level of laterality recognition, then there's no need to kind of stay within that component, and moving into that imagined movements is going to be the next thing. Again, does it change their comparable sign? That's what we're looking for with everything with this, and going back into why they're coming in the first place with this.
On that comparable sign, are you checking every visit for some of these patients, or are you spacing it out based upon their irritability level? How are you doing?
Yeah, so in general, I'm going off of the severity, but most of these patients are coming in with high severity. So no, usually I don't, because if I check it first thing when they come in, all right, let's see how this is moving. And that might be it for the day. I might see them for 1 minute at that point because they don't want to be seen anymore from there. So usually, no, I usually check it sporadically throughout.
Okay. And is that how you justify your treatment and your progress then?
Absolutely.
Cool. What other questions do you guys have? If you do think of any other questions you want to ask, please feel free to reach out to either me, Dr. Guarino, or Dr. Poepoe, and we will be happy to answer them. As a reminder, make sure you take the quiz and the course evaluation, and we will see you in a couple weeks for next grand rounds. Thank you very much.